This is a shared presentation with Miguel Ángel Mellado, a colleague from Palencia, Spain. I'm going to talk about our approach using DEBRICHEM for eliminating biofilm. You know that biofilm is a threat for treating chronic wounds because it doesn't allow a proper wound healing of the wound. And biofilm is one of the major barriers that must be addressed. We are very happy that now we have a resource for addressing properly the biofilm. And you know that the biofilm is a structure that it's very difficult to eliminate because for this you must cleanse, you must debride, and many of the solutions that we use in the clinical environment are not efficient for eliminating biofilm. This is why we are using DEBRICHEM in these cases for eliminating biofilm. As I told you, biofilm won't allow a proper wound healing of the wound. Biofilm means a delay on the wound healing. Biofilm means the use of antibiotics. Biofilm is a real challenge for wound care practitioners. You all know that I'm not going to talk you in depth about biofilm, but biofilm is present in about 80–90% of chronic wounds. And biofilm is an example of the adaptation of the bacteria for an hostile environment. And then it's a protection structure. Biofilm is composed mainly by water, and this is important because we are going to talk about a strategy that is using DEBRICHEM as a chemical debridement, and what we achieve with DEBRICHEM is a desiccation in an environment where water is the major constituent. Biofilm is also a threat for antibiotic resistance, and then it's important to have a right solution. Sometimes it's difficult to identify biofilm. We cannot identify biofilm at open A, and then we suspect the presence of biofilm because the wound is not progressing adequately. How can we manage biofilm? This is the key question. For managing the biofilm, we need a vigorous cleaning of the wound, and the goal is to create an optimal environment for wound healing. But we must eliminate biofilm. With biofilm, wound never will heal. How can we act? We can act preventing, we can act eliminating, and we can act killing. In the case of prevention, it's important a proper approach for cleansing the wound and using products that avoid the progression from planktonic germs to biofilm. And for the elimination, we have several options. For instance, debriding is basic. We can perform physical, sharp debriding, curettage, ultrasounds, etc. But the problem of these systems of debridement is that are not selective. They may destroy healthy tissue, and probably they are not effective for destroying a strong and complex structure as biofilm is. Now we have an option, and we are very happy of using this option, that it's chemical debridement. Chemical debridement, it's a new approach that allows us to destroy the biofilm. Destroying the biofilm, we are restarting the wound healing. We are interrupting this starvable situation for a proper wound healing. This is our new ally, and for resetting the wound. How does DEBRICHEM work? DEBRICHEM is an hygroscopic and dehydrating agent that what it does is eliminates the water in the biofilm. Remember that water is the most important component of the biofilm, and then we are, with this disruption in 60 seconds, we are eliminating the biofilm. You can find evidence about what we did is to ask for evidence, to use evidence. We have clinical evidence, and also we have lab evidence about the action of DEBRICHEM. And we are now to give you some practical tips about the use of DEBRICHEM. We know that it's a hygroscopic product, that it captures water molecules. Then it's important because sometimes healthcare professionals are aware of intact skin, of surrounding skin. In surrounding skin, there is not a great amount of water, and then it's safe for surrounding skin. And in the case of biofilm, it's water. It's important that in the biofilm there are proteins and extracellular matrix components that are going to interrupt the wound healing, and these products can translate into an infection. What DEBRICHEM does is it desiccates the biofilm through an immediate dehydration, and once the biofilm is destroyed, we have the conditions for a proper healing of the wound. Here you are some germs before the application of DEBRICHEM and after the application of DEBRICHEM. It's important what I emphasize, that in the case of surrounding skin, intact skin, the product doesn't affect. But it's important to take on consideration that in surrounding skin there are a lot of germs, not only in the wound bed, but also in the surrounding skin. Then it's important when we apply DEBRICHEM to take on consideration these margins of the wound for using the product there also. Okay? Our way of working with DEBRICHEM is, before using DEBRICHEM, we check that the patient is comfortable. We explain him the procedure. It's important that the wound is accessible. We protect the environment and we protect us, because it's when washing or cleaning the wound, we can have problem with nails, and we protect. It's important to check pain sensitivity. In some patients, the use of DEBRICHEM can produce pain, and then what we do is a pain assessment before using the product, and according with the status of the patient, we use one of another approach for killing the pain. We wash and remove the wound in order to eliminate any obstructing material that could interact with DEBRICHEM, and we dry the wound with gauze. Talking about contraindications, wounds in limbs that are ischemic, we do not use it because then we don't have the change of a proper wound healing. Osteomyelitis, abscess, fasciitis, wounds exposed to cartilage, and potential allergies to DEBRICHEM. Let me talk brief about pain management. Okay? We assess a lot pain because these patients used to have pain with their wounds, and we assess the type of pain, the duration of pain, the impact of pain in the quality of life of the patient, the factors that make it worse or better, and the characteristics of pain. It's important for us for doing this assessment, the location of pain, the temporal aspects of pain, and the severity and intensity. We have developed an algorithm for addressing pain before using DEBRICHEM. Here you are the algorithm. Tomorrow we are going to explain it in a poster, and with this algorithm we test the situation before using DEBRICHEM, the pain status. Normally we use EMLA cream. After using EMLA cream, we test the wound for being if we are managing the pain, if existing the pain, and if no, we escalate to other options like lidocaine, etc. We have an analysis previous to the use. I can share with you, if you are interested, this algorithm in Spanish. And what we do is we use the BS. Miguel Ángel is one of the other author. We assess the wound, and according with the BAS scale, we use an approach or another. In our practice, what we have done is to test the effect of the painkiller before using DEBRICHEM. We use a little drop of the product for seeing if we are managing or not, and if no, we escalate. Okay, but don't worry, we can share with you this algorithm of using, and then we use this dosage test for testing, and then we apply. If no, we use the World Health Organization scale of analgesia for increasing the approaches. How to apply DEBRICHEM? It's very easy. You must explain to the patient what we are going to do and possible problems that could, for instance, the perception of pain. We clean and wrap the wound. We cleanse, we eliminate, if you are using EMLA, we eliminate all the EMLA while cleansing. We dry the wound. It's important because remember that DEBRICHEM is hydroscopic. And once we are sure that we have proper conditions of analgesia, then we apply the product using gloved fingers. We also cover the edges. It's important to cover the edges because we realize we have used fluorescence and we have seen that the environment of not only the wound bed but the surrounding skin, there are a lot of germs. And then we apply the product. Important, just 60 seconds. 60 seconds applying the product. And then after that, we wash the wound with saline or sterile water. And we use a dry gauze. When we apply, we press the product. We learned it from Alberto. We press the product in order to increase the penetration of the product. And once the wound bed is now clear, the clinician can act in two ways. A more conservative way or a more aggressive way in order to debride more quickly the wound and to reduce, in other words, it's to reduce the time, the time process, okay? But sometimes some people prefer to use a conventional dressing or negative pressure wound therapy. Otherwise, some people prefer to practice a surgical debridement of the wound after having used DEBRICHEM in order to graft the wound and in order to reduce the occlusion. Here you are several clinical cases. In this case is a recalcitrant venous ulcer with calcifications arterials of 16 years of evolution. Here the situation, we have very old patients with very long histories of wounds. In this case, our patients are very complicated with plenty of situations. In this case, for the value proposition of the product, it's important two aspects. One is to avoid the use of antibiotics, and the other, the reduction of the time for healing. And for us, it's very important because we have a compromise in reducing the use of antibiotics. But as you can see, a long time, many treatments, many antibiotics, that it costs money. Okay. In this case, we cleanse and we disinfect the wound previous to the use of the product. We used an anesthetic emulsion with lidocaine, prilocaine, EMLA. with sevoflurane. Sometimes we mix according with the pain perception of the patient. We cover with we rub the wound with a film, and in this case we reduce the VAS punctuation from 6 to 1, and then when we earn 1, it's a good condition for using the product. Sometimes even we use blockage, according with the situation, blockage, but not in the operation theater, in an outpatient clinic. Important, 60 seconds. You mustn't protect the periune skin because we apply the product also in the periune skin. And in this case, after the application of the skin and the patient was had the wound with a painkiller, we perform a curettage. We wash, we perform a curettage in order to transform the biofilm into granulation tissue that allow us to use, for instance, pinch grafting, etc. Okay, in this case, we continued with advanced wound dressings. We continued with an anesthetic emulsion, as well as a charcoal silver dressing, and also using alginate, and in this case it was a venous leg ulcer, using compression therapy. And when we were sure that the granulation tissue was healthy and the wound was in proper conditions, then we performed pinch grafting, and we achieved complete epitheliation in 47 days. Remember that this wound was a wound of 16 years of evolution, and in there a month and a half we could I show you another case, and this case are post-thrombotic ulcers in a patient with phlebolymphedema and multi-resistant Pseudomonas of 1 year of evolution. Many of our patients have multi-resistant strains, and it's a big challenge for us. In this case, you can see the Pseudomonas. We use moleculite in order to identify the germs. We use the moleculite, and remember what I told you, not only in the wound bed but also in the surrounding skin. We also perform lab tests. This is a patient with a long history of using antibiotics, a lot of solutions. These patients are very expensive to treat or to treat without having success. In this case, we use the same approach, the topical pre-anesthesia of the bed, of the wound bed, the application of DEBRICHEM, debridement and curettage, and in this case, we use also, in the practice for biostimulation, we use a K-laser laser and negative pressure wound therapy. Here you are the pain approach. We move from 7 to 1, and then in this case the wound is ready for using DEBRICHEM. We apply the anesthetic solution about 1 hour, 45 minutes, an hour. We test that it's effective, and then we apply DEBRICHEM. Remember that in this case we do not have other chance. If we perform a surgical debridement, it's not going to be successful. We are damaging the healthy skin, and then for us, in this case, DEBRICHEM is an ideal solution because we can perform a very selective chemical debridement. And once the bed has been dried with a topical, with the desiccating solution, we remove with saline. We perform also treatment with EMLA and with dressings for managing the exudate, although when we manage the infection, we are managing reducing the exudate. We also used compression therapy. In this case, we decided to use a laser in order to stimulate the sick. And after that, we use negative pressure wound therapy, in this case a PICO system, in order to flatten the wound bed and to perform a dermoepidermal stem graft, a pinch grafting. And we could achieve the complete wound healing of the wound, and taking on account the cause of the wound, in this case a venous insufficiency, the patient using compression therapy. This is our approach. In some cases, according with the environment we're treating the patient, we wait. We use moist environment dressings. We use negative pressure wound therapy for progressing the wound. In some cases, if we can be more aggressive, we perform aggressive after being prepared the wound bed. We perform aggressive options in order to reduce the time of wound healing. Thank you so much.